Would putting your loved one on female hormone therapy, like lo-Estrin, bring down sexual aggression in a male living with Huntington's disease? Has there ever been any studies on this?
That is a terrific question. And as you said, I'm so glad that people are not afraid to ask about sexual experience in HD in general, particularly about aggression that seems to be sexually driven. There have not been terrific studies on this in HD, unfortunately. If you look in the world of treatment of sex offenders, which is where we get some of our information on this, there are a couple classes of drugs that are used with repeat sexual offenders. Not to say that people with HD are sex offenders. This is where we're getting our information, where there's been the most studied. So to back up for a second, putting a man on estrogen might not be the best thing to treat sexual aggression because you could cause breast development and also testicle shrinkage. There are a couple of alternatives. The simplest one, and one that I do use sometimes, is to use SSRI antidepressants. There are a number of SSRI antidepressants like Paxil, Zoloft, Prozac, citalopram. They're pretty common, pretty easy to prescribe. Pharmacies have them. For some people, being on an SSRI antidepressant, because it stops serotonin, which is one of the neurotransmitters in the brain, from getting degraded. So it increases the level of serotonin because it's not being degraded and taken out. For some people, increasing the level of serotonin in the brain calms them, helps with irritability. So that in and of itself can be really good. It also decreases sex drive. So we're using a side effect, right? Some people on SSRIs don't like them because they can decrease sex drive. But if that's a problem and it's causing aggression, then decreasing serotonin can actually be a good treatment. So that's a case where we're using a side effect of an antidepressant to treat something. There is literature from the world of treating sex offenders of using drugs that suppress testosterone, like the progestins and the anti-androgens. So that would be something where it might take a bit more effort to find a doctor who has experience prescribing this, but that is another option that you could pursue rather than thinking about giving estrogen for a man for that particular indication.
Great. The next question is for Emily. What is the most important thing to do before testing for HD besides getting life insurance?
That is a really good question as well. A very common question that I receive. I would say here at Georgetown, we do things a little differently than a typical COE, than a typical center of excellence. So when you call to schedule that initial genetic testing appointment, you're calling me directly, the social worker. And when you call, I want to know more of where you are in your HD journey. I want to know the when and the why. So when did you decide to be tested? And why did you decide to be tested or to begin this process? And more oftentimes than not, individuals who are calling me to be tested grew up in an HD family. So they grew up taking care of dad with HD, taking care of mom with HD. They grew up with grandparents, aunts, uncles, siblings. So they know what HD is. They aren't calling me to tell them what HD is. They already know what HD is. So instead, I am beginning that when did you decide to get tested and why did you decide to get tested conversation. And many people grew up their entire life knowing in the back of their mind that they were probably going to get tested at some point. And more oftentimes than not, it's more when I receive that call, it's because they're going through a major life event. So maybe they just got married. Maybe they're thinking about having kids or thinking about buying a home, college. They just finished college. They finally feel like they are established and have time to go through that process. So again, bringing in that, where are you in your HD journey? When did you decide you want to get tested and why do you want to get tested is so important. And by doing that, I'm able to bring up, what are you going to do if you test positive? What are you going to do if you test negative? And being able to manage those thoughts and feelings. I'm of course going to have the conversation about life insurance, long-term care insurance, the importance of advanced directives, but just want to continue to revisit where they are in their journey. Here at Georgetown, we are a bit unique as well because as a social worker, you can call me as many times as you need to. I am more than happy to sit down with you, to talk with you on the phone, do a telehealth conversation with you before you come in, while you come in, after you receive those results. Our genetic counselor is also free, so you can also connect with her as often as you want as well. So again, just being, I think, of course, having everything in place, long-term care, life insurance, making sure you have a good support system, but also making sure you're preparing yourself to have either a positive or a negative result.
Great.
Thank you so much. So our next one is for Dr. Stemming. And I always say Dr. First Stemming. I always forget to.
I'll take either. It's 50-50.
Okay.
Depends on how much I like my husband.
Yeah. Would you recommend someone with HD in later stages getting a feeding tube?
Yes, another great question. And first, thank you so much for having me today. Thank you to all the brave folks that submitted these tough questions. This is a question that we get frequently in our clinic, and unfortunately, I don't have a perfect answer or solution. This is a question in which the answer differs for everyone. So, as most of you listening know, as HD advances and progresses, swallowing becomes more difficult. And so you may have heard the term dysphagia, which just means difficulty swallowing. And dysphagia can put individuals at risk for aspirating. So that food or liquid that you're consuming may end up heading down the wrong pipe and end up in the lungs instead of the intended target, which is the stomach. And so aspiration, unfortunately, is not uncommon. And if folks aspirate, they may, in fact, develop an aspiration pneumonia. We know that it can be very difficult for individuals with HD to keep their weight up, to maintain a healthy weight. And there are various reasons for that. And malnutrition is not uncommon as the disease progresses. And if our patients are in fact experiencing dysphagia and they're having a tough time keeping their weight up, we may have this discussion about whether or not to place a feeding tube, otherwise known as a PEG, which stands for percutaneous endoscopic gastrostomy. I can't talk today. And this is actually a tube that's placed directly into, or a catheter that's placed directly into the stomach that allows individuals to receive liquid nutrition, so artificial nutrition. And there are many factors that individuals really need to think about and talk about with their loved ones before pursuing potentially a PEG. I do like to initially bring up just some points and clarify some misperceptions that many of my patients may have about a PEG tube. So if an individual has a PEG tube placed, importantly, they can still consume food and liquids orally. We will often call that pleasure feeding. So because most individuals enjoy eating and drinking, and so that can still occur if you have a feeding tube or a PEG tube in place. Most individuals that have a PEG tube, have a feeding tube, will receive their foods intermittently. So they don't have to be connected to feeds 24/7. They may be, but they don't have to be. So they can receive what we call bolus feeds. The procedure itself to place a PEG tube is fairly straightforward. This is usually done in an outpatient setting by one of our gastro-GI colleagues and gastrointestinal colleagues, and it's a fairly straightforward procedure. However, there can be complications. And so even though the procedure itself is straightforward, there can be complications, with one of the most common complications being an infection. PEG tubes, even if individuals are not consuming foods orally and have a PEG tube placed, PEG tubes do not necessarily decrease or eliminate the risk of aspirating. And that's something important to be aware of. We don't have a ton of literature surrounding PEG tubes in individuals specifically with HD, although there was a relatively recent study published in 2021, and Dr. Sam Frank, who will speak with you later today, was actually the senior author on this paper. And this was a paper it was a retrospective chart review. So the authors reviewed charts from individuals that were in a long-term care facility on the East Coast, and they reviewed the charts from 148 individuals. 39 of these individuals actually had a PEG tube placed. And ultimately, they found that the individuals that had PEG tubes placed had an extended duration of life, on average 3 years, along with decreased cholesterol levels. However, individuals that had PEG tubes placed they found that they did not have a decrease in incidence of ulcers or a decrease in the frequency of pneumonia, and the PEG tubes did not seem to improve their nutritional status. Now, this was, as I said, a chart review, so we know there are inherent limitations to these types of studies, but it gives us some data in HD. We don't know about quality of life and what PEG tubes mean for individuals when it comes to quality of life. And so there are still many questions if you're really reviewing the literature as to whether or not we should move forward with the PEG tube. So the bottom line is, and I know this is a lengthy answer, the bottom line is there's no absolute wrong or right answer when it comes to placing a PEG tube. It's really important that you have this discussion, if you can, with your loved ones early in the disease course when you're thinking about your advanced directives. It's actually an important discussion that we should all have, with or without HD. If we get into a situation when we can't make this decision for ourselves, we really want our loved ones to know what decision we would have made. And so please just absolutely know that it's appropriate to ask your neurologist, your primary care doc, ask this question and know that it's okay to be conflicted about whether or not to move forward. But there are absolutely folks that can help you and guide you in trying to make the best decision in pursuing a PEG.
Okay. And Dr. Stemming, do you feel like another conversation that should be had is with your loved one, if they do decide to get a feeding tube, there is going to be a time where you're going to have, as the caregiver, you're going to stop feeding, right? Is that something is that a conversation you should have with your loved one? When do you want that to happen? And then the doctor advises it, or what does that look like?
So that's right. If an individual does have a PEG tube placed and they're nearing the end of their life, then you may have to make the decision as to should we stop the tube feeds? And that's not an easy decision to make. And so I think that's a decision that you need to make with your neurologist, with your care team. Likely you'll have a hospice palliative care team on board as well. Hopefully you'll have a palliative care team working with you to make that decision. And I think it really gets back to quality of life, and what quality of life is different for everyone, and it changes throughout the disease course. And so trying your best to determine whether or not your loved one in fact maintains some quality of life, and asking your care team to help you in making that decision. And I think Dr. Anderson, did you want to make a comment?
Yeah, I just wanted to add, I've had some patients who are just very confused, and it's hard for them to keep from pulling on the tube or scratching on the tube. So that can be a limitation if somebody is likely to try to pull the tube out themselves. And I've also had patients with really bad chorea, where we've had the discussion of, we need to get the chorea under control. Otherwise, I'm concerned the tube is going to come out because you're moving so much. And a question of how much medicine do you need to get the chorea under control, and would it make you more sedated? I don't know if you've run into those situations too.
Absolutely. It can be really challenging, especially like you said, if folks are confused and they know they have this tube in their stomach and they may be picking at the tube, and that of course can be dangerous and increase the risk of infection and complications related to the PEG.
Yeah, that was great info. Thank you. This next one is for Dr. Anderson. My husband is addicted to pornography. He isn't hypersexual with me, but he watches sexual-based content on the internet constantly. I am worried about him going to a site that he can be in trouble for being on, but he isn't hypersexual. So I am not sure if medication to bring down hypersexuality would be appropriate.
That is a really difficult situation. And I agree, it's hard to know sometimes what's driving it. A couple of thoughts on this. So she's probably already tried parental controls and the other things. So if he's using streaming services, adding parental controls to keep him from reaching certain sites could be helpful. If he has access to credit cards, maybe taking away credit card access so that he can't pay, because a lot of the problematic materials might be behind a paywall, so that could prevent this. maybe taking a look at what his day is like. So are there other activities that you could use to distract him or keep him away from the computer? Sometimes people do this because it's reinforcing, but they're also bored. So if he had more going on, would that be helpful? I know it's hard because you're probably working, you might be taking care of kids. So it's hard to program activities. Is he someone who could benefit from getting out of the house to a date program or something else where he has a bit more going on? The other thing I would urge you to do is make sure that you talk with your care team or your local general practitioner about this and get it documented somewhere in his medical records. I know it's embarrassing to talk about this face-to-face with your physician, but it's really important to have it documented so that if something does happen, there's medical documentation that this started after the Huntingtons, it's related to the Huntingtons, he's not a criminal, you can document even that he has poor judgment and he may not realize that the things he's doing are off limits. And that could help if he does get into some kind of trouble.
That's
And,
great.
and I'll just add as well, I know Dr. Anderson mentioned the restrictions, parental control. I have seen, it's called MIGIRI. It's an app. It's $10 a month. It uses a psychotherapy approach. You have to pay for it, but thinking outside of the box, if you have done the typical restrictions, this might be another option for you. I do appreciate this question. We do receive this question in our clinics. So if I had to guess, Katie and Katrina probably received a lot of questions like this. So do not hesitate to talk to us at the Center of Excellence with your care team, because we can help you process this information, possibly connect you with a therapist, either a marital or an individual therapist that can work through this with you as well.
Thank you. Thank you for that. Yeah. Dr. Stemming, will my loved one know who I am at end of life?
Another really tough question to ask, and thank you for asking this question. I think the answer is yes. We know that cognitive decline does occur in individuals with HD, unfortunately. But the cognitive impairment that occurs in HD is different than that of, say, an individual with Alzheimer's being the most common cause of dementia and cognitive impairment. And so we know, however, that it will take longer for folks with HD to process. And so they may respond very slowly, but they will know who you are, and even in the end, and they will be able to hear you in the end. And I've gotten that question as well. So even though they might not be able to verbalize, they might not be able to speak to you or really indicate that they know who you are, they will know who you are, and they will know how much you love them. So thank you for asking that question.
The next question is for Joey. Do you think telehealth is a good option for people with HD that need speech therapy?
First, I just want to thank you for having me today. But yes, I think telehealth can be a great option, and it's so much more accessible since the COVID-19 pandemic, which is a great thing. I think it's especially a great option if you're looking to work with a speech therapist with experience with HD. Here at Georgetown, our speech therapist is licensed in DC, Maryland, and Virginia, and can provide telehealth to all 3 states. Telehealth can be a great option for individuals with transportation issues, a caregiver who's unable to take off work, or just for an individual who just has a few questions. I think it's also important to establish a relationship with your HD care team. So telehealth can be a great option for individuals who may not be at that later stage, but just want to know what may be coming down the line and what some of their options are. And it may make those tougher conversations easier to approach. Obviously, not all speech therapy services can be provided via telehealth, but it's a good way to get a baseline, I think, and determine if you need to be seen in person. We had our speech therapist recently speak at our virtual educational support group and shared some amazing tips and tricks on communication and swallowing. So yes.
Great.
That was one of our board members, Melissa. We saw her. I was like, one of our board members just came on. The next question is for Dr. Karen Anderson. My loved one does not like wearing clothes. I'm not sure if it's a sensory issue. Any suggestions on medications or techniques on getting him to at least put pants on? I am worried about neighbors seeing him or something like that and getting indecent exposure.
Yes, I have encountered this question several times over the years I've worked in HD. And it is sometimes a sensory issue. So one question is, have you talked with your loved one about different types of clothes? So is there some material that seems to be irritating his skin? Are the elastic waistbands irritating? Would a drawstring waistband be more comfortable? You don't need to wear underwear, just wearing shorts of some kind around so that you're not completely exposed if you have to answer the door or if you have the shades open and the neighbors can see you. Sometimes it's part of more obsessive behaviors where for some reason the person gets very fixated on the clothing being maybe dirty and needing to change the clothes. And then the next step is I just won't wear clothes because all my clothes are contaminated or dirty. So hard to know what's driving it sometimes. A couple of things. So one question besides figuring out texture of clothing, is there some piece of clothing that could be tolerated for most of the day? Is the person willing to spend time in rooms where the shades are pulled? So if you don't have other family members like young kids who don't want someone walking around naked, but if you have a couple rooms where the family member could spend time without clothes, where the shades are pulled or it faces away from the neighbors so no one else is bothered, that's a thought. Having a conversation with your neighbors if you're comfortable doing that. You don't need to advertise, I have a person who doesn't wear clothes, but getting to know your neighbors a bit, helping them understand there's someone in the house with a neurological disease so that they have a little more context if something does happen and your loved one is seen not wearing clothes. So they know they can talk to you. They don't need to go straight to call the police. There are some medications that you could try. So if this is driven more by obsessive, my clothing is contaminated, my clothing feels bad on my skin, you could try an SSRI antidepressant. Sometimes those can be really helpful. Occasionally, if someone has really bad obsessive thoughts, we might go to an older medicine called clomipramine, which is a tricyclic, which is a little more complicated to use. But there are a couple of medication options that can be really helpful with this also.
Thank you.
The next question is for Emily. Are there any resources, for medication prices? We live in California and do not qualify for Medi-Cal or Medicare, but do not make enough money to pay for his specialty medication.
I think the thing with medications is that one shoe does not fit all. So especially thinking from a full country perspective, there's so many different states that have so many different resources. And I often compare it to extreme couponing. If you're familiar with using coupons, it's a process. You have to go through the dates. You have to find the stores that are taking those coupons. And a lot of times with medications, you have to shop around. So if one person recommends that this worked for this family, it doesn't mean it's going to work for family. Some of the COE social workers most COE social workers have a list of different companies that can prescribe lower priced medications. Some that come to mind are RX Hope. It's a mail order, so most states accept the RX Hope. CSI Pharmacy is another, healthfoundation.org. Long story short, I could give you 10 or 20 different companies. Call us as the social workers and we can help you locate the local resources.
Awesome.
Yeah. Our next question is for Joey. Do you have any information on trials for me? I am not symptomatic, but I did test positive for HD. I am in an observational study, but I'm actually looking to participate in a clinical trial.
Yeah, so first I'll say with research, there is always new information coming out every day. So I will add that it's really important to connect with a COE, maybe that does research, or an HD research site to get the most up-to-date information and also the most accurate information. I will just plug HD Buzz, which is where I also go to get up-to-date information on research. Again, I will add that inclusion and exclusion criteria for clinical trials differs. So it is hard to determine solely based on a CAG number if an individual is eligible to participate in the study. So again, really important to connect with a COE. Our research team at Georgetown is absolutely amazing. I may be biased in saying that, but they truly are and are all willing to talk with you, talk through what trials we have, see if you're eligible and see if you're comfortable in participating in a clinical trial. Research is hope for the HD community, and it's because of your willingness to participate that research moves forward every day. I will just say that at Georgetown, we have 2 observational trials, Enroll HD and HD Clarity, and currently 4 clinical trials, Surveyor, Dimension, Proof HD, and Connect HD2. We also have BU-HDRS. Again, this information is always changing. New studies are coming out. So again, really important to connect with a Center of Excellence or HD research site to get the most up-to-date information.
Thank you. And I think we just had a comment come through that there is a group of, just to add on with you, Joey, that there is a group of advocacy. They're doing amazing work and they are working on bringing a greater awareness to this more prodromal, pre-symptomatic population. BJ and Seth and Lauren and Chris, and I forget, I'm blanking, just did a talk with the FDA patient listening session, really talking about how they really do want to be a part of the change. We just did a comment to let you guys know their advocacy is working on trying to change that.
Our next question is for Dr. Simming. I have heard that thickening drinks to help with swallowing can also cause people to get dehydrated. Is that true for people with HD?
Really good question. So as I mentioned earlier, swallowing is affected in HD and can worsen as the disease progresses. And so if an individual is experiencing coughing or choking after eating or drinking, it's really important to let his or her neurologist know, or primary care doc, so that they can order a swallow eval, a swallow study. And after a swallow study is done, it will be done with a speech therapist. We love our speech therapy colleagues. We'll likely get some information as to the integrity of the swallowing function and whether or not we need to modify the consistency of foods or liquids. And so if in fact there is some dysphagia, the speech therapist, and given in examining the results of the swallow study, may recommend that an individual thickens their liquids to make it easier to manipulate that bolus of liquid and ultimately swallow it safely. And so if in fact you're needing to thicken your loved one's liquids, the question is, great, does this actually worsen dehydration? Because we know that the individuals that are having trouble with swallowing, that are experiencing dysphagia, may be dehydrated. There actually have been some studies done examining the bioavailability of water in individuals that are consuming these thickened liquids. And it seems that in fact the thickeners that you can get over the counter do not actually cause dehydration. It's probably the dysphagia, the difficulty with swallowing itself, that contributes to dehydration. In addition, some of these thickened liquids can be, if and when individuals consume large volumes of thickened liquids, they can experience satiety, or they can feel full and less thirsty, even though they may not be receiving as much hydration. We generally recommend, when individuals are thickening their liquids, that they take small amounts, consume frequent small amounts, so that they don't feel too full and can continue to hydrate sufficiently. I'd like to give a little shout out to the Help for HD cookbook. I know that's something that was published relatively recently, in giving our patients and families different tips for getting their hydration and nutrition safely.
Thank you.
Is it me? I got so stuck on, because what I was thinking as you were talking is I didn't even think that getting full, like you wouldn't want to stay hydrated. So going small is, sorry, I got stuck on that idea. You guys will say stuff and I'll start thinking about it, and I'm thinking about what we can do next. Sorry.
No, good.
Karen Anderson, is it okay to be on mood stabilizers for long term?
So the simple answer is yes, but it is important, depending on which mood stabilizer you're taking, that you see a doctor regularly to monitor a couple things. So we know from general psychiatry, where we have patients with bipolar disorder and other conditions, we have patients who are on mood stabilizers from their 20s onward for many years, that generally people do okay with mood stabilizers long term. But there are some monitoring labs that need to be done if you're on particular mood stabilizers. So I'll just mention a couple. One of them is Depakote, which is pretty common, valproic acid. It's important to get your liver functions checked once a year, once you're on a stable dose. Carbamazepine, which is Tegretol, which is one that we use sometimes, where it's important to get your blood counts monitored. One of the newer ones, Lamictal, which is lamotrigine. You monitor for a rash, which can be a very severe side effect, although it doesn't usually occur once someone's on a stable dose. Some of the antipsychotic medicines that are also used as mood stabilizers, like Seroquel, which is quetiapine, that's a matter of monitoring for weight gain, which is usually not such an issue in HD, and monitoring for diabetic changes. So in general, we know that people do very well. We know that controlling aggression, irritability, huge mood swings is much, much more beneficial than the small risks that you do see with some of the mood stabilizers. But it's important to see your doctor and at least get yearly monitoring of some kind, and to know specifically for the mood stabilizer that you're taking, what type of monitoring you need to have.
Great, thank you.